Hi, I'm Brad Power, and this is the Cancer Patient Lab, and we're honored to have with us today Jill Hunt and Phil Leming. They're with Cincinnati Cancer Advisors and Naples Cancer Advisors. And I've known Phil for some time, and when he was transitioning from starting up Cincinnati Cancer Advisors, and they provide second opinions. Is it for free or is it fee-based?
It's for free, sponsored by philanthropy.
Yeah, sponsored by Flanders. So in that regard, it's somewhat like our friends at Cancer Commons. But Phil's seeing people in person as you would at as a like a regular visit to a medical professional, which he will describe in more detail. And he has some particular points of view about the way the system works and the way the healthcare system could be improved based on his many years of experience that I think you'll find very interesting. Before we get started, I should just do the disclaimers or the housekeeping things at the front. Of course, this is for information purposes only. This is not medical advice. We try to arm our patients with information they can take to their medical team. Second of all, everything we do is open and public. And so if you're concerned about your name, image, or anything you might say being made public, you can change your name, turn off your camera, and not say anything. And thirdly, we are a nonprofit 501c3, and we depend on donations from people to keep us operating, and we would appreciate any donations which you might make, which you can do on our website at the donate button. And with that, I'll turn it over to Phil and Jill. That's a nice ring, Phil and Jill.
Well, Jill and I have worked together for 22 years now, so it sort of meshes pretty well. Yeah, my background is I'm a medical oncologist. I did my most, I guess, recent training, which is now a number of years at the National Cancer Institute outside of DC, and our subsequently went into sort of an elite private practice in Cincinnati for many years, and then joined one of the hospitals. But I was the founder and director of the cancer research program at the Christ Hospital in Cincinnati for 30 years or so, and have a long-standing background in clinical research as well as specifically in the area of malignant melanoma. And approximately 5 years ago, Jill and I were sort of persistently noticing frustrations in the healthcare system, and we're frustrated with leadership, and so we decided to escape the world that we've lived in for a long time, and we're offered an opportunity to establish a completely independent, non-denominational second opinion oncology program in a way that was somewhat unique, and that it was sponsored by a very large foundation of business people who wanted to do something good for Cincinnati, but didn't trust hospital systems. And we were tasked with starting this concept by Dr. Bill Barrett, who was the idea person behind all of this. And we were, and Jill can jump in a little bit, we were given a little small office with very little furniture, no phones, no computers, no electronic medical records, and say, okay, make this happen. And I was telling Brad that early on I was putting connection with Brad when we were trying to get off the ground, and his contacts, help, and support was extraordinary, instrumental in us being able to develop and get off the ground and become what we are now. Jill, you want to comment in there?
Yeah, it was actually really kind of fun because when we first started, we really weren't even given a direction short of let's start with second opinions and then just see where it goes. And so it allowed us to slow down the care of cancer patients and just give them the time to ask questions, to really educate them on their diagnosis and their treatments. And then depending on what part of their journey they were on, whether it was a new diagnosis, whether they had advanced disease and were now progressing on standards of care, or had failed multiple lines of treatment and now are looking at potential clinical trial options. No matter where we were, we treated every patient the same way, in the sense that every new consult was blocked for 2 hours. And so by the time that they left, every question that they had and every question that anyone that they brought with them had was answered. And we opened our doors in January of 2020, not realizing that a pandemic was right around the corner. So in a time when cancer patients could not take anyone with them to the doctor's offices, to their treatments, to any of those appointments, they were able to bring their families with them to our appointments, and they were given the time to process and to answer all of the questions. And then what we found was, as time has evolved, just like with most things, you realize, oh, there's a need here, there's a need here, there's a need here. And so our program has continued to evolve to fill in the gaps for cancer patients and the care that they receive. So it's been a really fun journey, but it was almost comical in the beginning, because when you put two completely clinical people in an office and say, hey, just do this thing, it was, we knew how to take care of people, and we knew that we knew how to do that. When we needed help when it came to, we walked in on the first day and we're like, oh, we don't have a phone, and we don't have any internet. So it was a fun journey. And so now we've got a great supportive team, and we're really impacting Cincinnati and the Naples area, just with all of the patients that we're reaching.
Yeah, so what we've evolved to now is we're no longer in a little bitty office, and we have about 20 people total. And one of our other medical partners, Dr. Abdul Jazzy, was the head at the university for a number of years here, and after that was the head of the largest cancer program in Saudi Arabia for 15 years in Riyadh. So he heard what we were doing and moved back from Riyadh to join us in this. And he's our innovation international person. Robin Zahn joined us as the breast specialist, and she's just finished a year as the president of the American Society of Clinical Oncology. And Andy Ginigundo is another nurse practitioner who was just elected as the president of the, what is it, Jill? It's the Oncology Nurse Practitioners Organization nationwide. So, and we've got a lot of talent. We've said it. I'm the medical director, and I set the tone. The tone is physician first, consultant second, meaning that every patient gets an ultra comprehensive internal medicine assessment of every square inch of themselves. And that's done prior to us addressing the oncology question, as the philosophy being that if you don't understand the person that has the cancer, that you can't effectively do a good consultation for the cancer problem. And as time gone, as Jill alludes, as time's gone on, we've been able to be a window into the changes and good and bad, I guess, of healthcare, and have been able to realize that our role is way more than just being a consultant to give people new ideas of their particular cancer. And what we're picking up is a lot of deficits in healthcare that patients come in with, and that we are now having to figure out ways to help people, and also to help physicians deal with the systems they're working in, and filling in the gaps in not only primary care, but the oncology space. And then we're finding that part of our role is almost like a training ground to teach patients and families how to get the kind of care that they really need within the current healthcare system. And it's different than it was 5 and 10 years ago. And particularly for older patients who are accustomed to a single internist watching over them, the whole world is flipped up. And that's not the kind of care that people are getting now. But they have to, you can still get good care, but you have to understand this and work with the systems.
Can you give some examples of some of those changes you've seen and things that patients should be aware of?
Yeah, and Joe can jump in on this too, is what's kind of surprising is the number of patients and families that we will, we'll be getting into all the history in the patient, and we realize that the patient and their family, they're seeing like 5 and 6 different doctors. And I'll look over at the family and the patient and I say, okay, well, who's taking care of you? And the family and patients look at each other and they, very commonly look at each other and go, well, we don't really know. So the system is very fragmented. It's very tunnel visioned in regards to capable physicians that are not either allowed to or are not taking the effort to comprehensively care for people, but refer them to a specialist of that area. And it becomes burdensome for people with, for transportation. They may not feel well. They could be older. There's a lot of factors where we're finding situations where one doctor should be able to handle a lot of this, that they're just not, the systems are not facilitating that. They're facilitating multiple referrals to multiple specialists rather than one or a few physicians caring for the people.
And then the problem with that is that you have, say you are actively on treatment and you're seeing your medical oncologist, and your medical oncologist elects not to manage the respiratory infection that you have and tells you to go see your family physician for that. So then the patient goes to see their family physician, and the family physician treats them with antibiotic X and this and that, however, doesn't actually communicate it with the treating medical oncologist who is actively treating the patient for their cancer. And so then, without any real awareness, they've now, potentially put them on a medication that could impact the effectiveness of the treatment that they're on, for the sheer fact that nobody's communicating on what they're doing, taking care of the same patient. And it's really frustrating, because when Phil and I were still actively in practice at the hospital, once a patient was on treatment, we treated them for everything. It didn't matter. You get the sniffles, you get a sore throat, you get a cough. I don't care if you have a primary care physician. I'm glad that you have that person. They can refill your yearly medications. But while you are actively on treatment, because there are so many things that can impact the effectiveness of your treatment or how you're managed, we're your quarterback. We are your bus driver, and we'll keep everybody else posted. So it's really hard, and we really try in this role to empower patients to make sure, number one, you know who's driving your bus. But number two, you make sure that all of the people that are on the seat in your bus are communicating with the bus driver. Because if you go to your cardiologist and they pick up something and now they're ordering additional testing and they've put you on a different medication, but they haven't talked to your medical oncologist, and potentially one of the drugs that you are on is potentially cardiotoxic. That there are so many things that intertwine, that if they're not communicating, the care of the patient not only can be fragmented, but overall can impact and have poorer outcomes for the patient.
So you have the luxury of doing the right thing, of designing what's best for the patient and being integrated around what's best for them. Alan has a question in the chat here asking about the cost side of this. It is, I mean, I guess as you're describing, if they have a negative consequence from a side effect that doesn't get managed or something, a complication with an interaction with something else, then on net, they're worse off. But at least from some standpoint, the luxury you have of spending, as you said, 2 hours on that intake is something that I don't know if everyone has, you know, in the regular system has
So,
luxury to.
Well, the only thing the other thing, Brad, that I would say that along this same line is a disastrous level of physicians not examining patients, and multiple examples. For instance, where a patient has a disease that's metastasized to a lymph node, say a lymph node in the neck, and this is a real example, actually. A patient with a known malignancy had evidence that the patient and their husband palpably noticed lymph node enlargement in the neck. The patient called their family doc. The family doc did not examine the patient. Patient was referred to a thoracic surgeon because a CAT scan said there was some nodes in the chest. The thoracic surgeon never examined the neck. The thoracic surgeon took the patient in for an invasive procedure surgically to biopsy a lymph node in the chest, when in actuality, there was easily detectable, palpable nodes in the neck. The procedure did not get adequate tissue in the chest. The patient was then sent to an ENT doctor who did examine the neck for the very first time out of 5 physicians and commented that the nodes in the neck were obvious. And they did a simple neck biopsy of a node and got the diagnostic answer. But if you looked at these kind of cases, the cheapest, most cost-effective thing to do is listen to a patient and examine them, and that could have, the cost difference in with that on that one patient, not counting the morbidity, was very significant. So what we're seeing is, patients that have been seen by 4, 5, 6 doctors, all of their notes will document something on an exam that's like a normal abdominal exam. And we bring the patient in and examine it, and the liver is halfway down to the pelvis and grossly enlarged and abnormal. And everybody they're documenting their exams, but they're probably never not doing them. And in many clinical settings, your ability to help people is stemmed from listening to the patient and doing an exam, which in a lot of settings, that saves a lot of money and morbidity. But we're seeing and this is a common finding that we're seeing, whether it's a person in an academic center or in private sectors. It's in the last 5 years, it's been a dramatic increase in people not getting thorough examinations. And in occasional settings, that could be a major impact. So, it's not trying to blame docs because they're given so little time to see patients. It's easy to write, 12 scan orders. It'll take no time for that, but it takes more time to do an exam than it does to order an expensive test. And not uncommonly, if patients go to emergency rooms, the doc that's seeing them doesn't ever examine them. They get as far as the doorway, order a bunch of CAT scans and blood work, and walk out. So the one thing that we always point out is whether you're in music, medicine, or martial arts, the basics of a profession are the basics for a reason, and that the difference between a master in those professions and a beginner is that the master does the basics correctly every single time. And what we're seeing is the basics are being pushed out of the way by technology that is not always the best thing for a person.
It sounds like it also could be lower cost on net if you're saving those expensive tests.
Well, and just and it's also the timing of cases, and it's like we try to teach residents and people and other docs is, in our world, it's not that we know everything, because we don't. That's probably the first step is realizing that you don't know everything, and then realizing that it's not so much it's how you think. And so any patient that comes in, we can help them, and we can think through the problem and then facilitate what's in their best direction to deal with that particular cancer. And so like you pointed out, we have the luxury of time, and the average physician spends most of his time documenting epic notes so that the hospitals get paid, and has very little time to do the actual doctoring.
There's been some discussion in the chat about people wanting to access your services and where you are available. Jill, you had a response there. Do you want to just give voice to what you'd already written down there?
Yep. So if you want to learn more just about our organization and things like that, you can go to our website, which is cincinnaticanceradvisors.org. Several people have asked what states that we currently are working in. So the rule currently, especially if we are doing telehealth visits, is that we have to be licensed in the state in which the patient is actively in when we see them. So for our docs in Cincinnati, they are licensed in Ohio, Kentucky, and Florida. Dr. Zahn, who sees our breast cancer specialist, she is also licensed in the state of Indiana. Mark Randall, who is our gynecologic tumor specialist, he is also licensed in South Carolina. And then MJ, Dr. Jahanzeb, who sees breast and lung in our Florida location, he is also licensed in Florida and Ohio. That's everything.
And I'm in Maryland also.
Oh yeah, and you've got Maryland. So we've had some patients, like we had a patient who lived in West Virginia, just across the border of Ohio, and they literally grabbed their laptop and their AirPods and went to a Starbucks across state lines. We've made it work for patients who aren't necessarily in one of the states that we actively are licensed in. So if someone is located in New Hampshire, could they travel to see you in Maryland? Yes.
So
can we ask live questions or no?
Yeah, I was just going to say, typically we would do the raise hand feature so I can call on you, or we use the chat, but we're a small group today, so just jump in.
Well,
yeah.
Can I raise my hand?
Yeah, there you go.
So if they travel to you, and say they do the initial consultation, but they want, of course, they're going to continue their chemo and their actual treatment in their home state, or their home area. You still quarterback and communicate with their primary, whoever's overseeing the chemo and radiation in that area, or do you take that over? How does that work?
So I would say that
So
we're not the quarterback. We might be able to coach the quarterback and kind of help them along, maybe make some connections with some national thought leaders, or other, make recommendations in regards to potential treatment options or testing, or whatever else the patient needs. But at the end of the day, it is ultimately at the discretion of the treating physician to take our recommendations or leave them. So although we've been used to being the quarterback, and it is really hard to not be the quarterback when you know how to do it the right way. But it also empowers and enables the local and treating physicians to step up their game. So
yeah. And I think, what you're saying is, the way our healthcare system is built today, I've got many dear friends who are endocrinologists or primary care physicians, and the way the health systems are is they want, they want you to be Chick-fil-A. They want you to be efficient and get more patients through, because then they can build the RVUs. And every patient, one of my dear friends, she sees a lot of the geriatric, where it's a large, they have a lot of comorbidities, don't have the time. She's like, I can't do a 15-minute visit and do justice. And that's where the challenge is. Even in oncology, all these other services, it's all about the RVU and the time spent with patients. And what gets missed is all these, everything that's going on, and the handoffs and communication. I'm a speech therapist in my first life, and I saw a lot of head and neck cancer patients, and our local ENTs would find laryngeal cancer. They would cut it out and never send them to an oncologist. I would say I really think trying to not cross any lines, but I would recommend that they just get an opinion, because I knew that they weren't being treated completely, and there was going to be a reoccurrence, a likely reoccurrence. So I would inadvertently, but it happens way more often. And the challenge is patients and families, if you're not in the medical field, you don't know what to ask, and you don't know what you should be doing. So the medical community, we should be guiding them and putting them, giving them the best possible. And I thank you for doing that there at your.
But I think you're right on the money there on the, is what we see the same situation in that, we were all trained like special forces, in such that, you were an internist first, and then you were a consultant, so that when a patient came in with a cancer thing, you didn't tunnel vision the answer on the cancer. You treated the person as an entire thing, and you kind of had to be a physician. And honestly, I'm a little hard-nosed, but I don't give docs a break for telling me that they just don't have the time. Well, then push back on the system. The problem that you run in that's developing, though, is a lot of the young people that come out unless they're coming from wealthy families, are carrying these astronomically high school loans. And so if you got a young person and they're almost always being, joined into some system that owns them, they can't push back too hard, because they got to have a job to pay these ridiculously high loans, which can be anywhere between $300,000 and $500,000 straight interest loans. That so there's a whole dysfunction in the entire healthcare system that is in that their argument that there's not enough physicians, but yet the application approach to medical school is ridiculously bizarre in the U.S. and they're not fixing some of the basic causes. And so what happens is everybody's shifting to technology, which, where all you really need is one doctor, now you got six. And you can't tell me that that's not more expensive, because you go to a doc and they feel a tendency that they've got to do something, but maybe, if you just had one person looking over it all, you could avoid a lot of cost, a lot of hassle to people. And now the systems are such that the standard of care is that, well, you shouldn't be taking care of this, you should send them to an endocrinologist. And when we did the work, we didn't need an endocrinologist, but if the standard of care becomes this for everybody, then if something goes wrong, are they medical legally at risk? So there's all these screwed up factors in healthcare right now that could be easily dealt with by empowering physicians to be physicians. But the systems are lining up against them a bit. So part of what we do, we find, is it's necessary to empower patients and families to give them the okay to push back, to ask questions, and to be a little more assertive in a nice way. And then we're a backup. And if they have problems, we can be their, hired gun. But the reality is the system is complex, and for people that are not in the healthcare world, it's overwhelming, particularly if you're dealing with older people. So yeah, if you can sense a level of frustration that we're feeling, it's real, because it isn't hard to take care of people. It just takes time, and and it's actually cheaper to make the correct diagnosis and avoid stuff than it is to do it the way we're doing it.
Phil, I just wanted to pick up on a conversation you and I had before, which was, you said when you give these second opinions, often you spend the time with the patient and their family so that they get all their questions answered. They now understand much more clearly. It maybe confirms what they were already getting treated, but now they understand why and wherefore and how it fits and everything. And then it allows them to become the engaged patient because they understand more. Can you speak to that contribution
Yes.
you make, so that you basically return them to their doctor, a more effective patient than
right. So we'll just give you an example. Jill and I just saw a consultation before we started the thing here. Is a gentleman with a moderately high risk melanoma with lymph node involvement, and was seeing a good local physician getting immunotherapy. And the treatment is correct, but we methodically go through and explain the basics of where, the basics of the diagnosis, the cancer stage, and bring it down to basic common sense. We describe it between mechanical and personality of the cancer. But then we also pull out the original research data that proved that this immunotherapy drug had benefit in survival and why, but also showed the patient the survival curves, so that we could actually point out that, yes, here's the benefit, but you're not without some risk. But in the time frame, if you get out a 6 months, your gambling odds are better. You get out a year, they're much better. And if you get out to 2 years, you're almost home free. But with that is the actual truth, the data that they can work on, so the patient can be appropriately aware of what he needs to be doing, but also to eliminate the inappropriate terrorizing fear that they're going to die. People go away with, okay, I understand this now, and I understand why I'm going to have to get scans frequently during this period, and it'll be better in a later period. We also explained that 80% of the recurrences are something you can pick up on your exam, so you and your family should self-exam this, examine the area, and so the patient goes away. The doc was giving the right drug, but the missing part for the person and their family was the understanding and the reassurance, and the fact that the gambling odds were actually quite good for the patient, but he still had to be vigilant, and that's a real-time example. We just finished 15 minutes before we started this event. Jill, you want to add anything?
No, I think that as you're talking, I'm over here frantically answering all the questions that are going into the chat. So just to hit, just in case anybody isn't looking in the chat, some of the things people are asking are, how, let's see, there was a really good one. Sorry, there's been a lot. I've been busy.
Well, some of those have come from Mick Davis, and he's got his hand up. Why don't we let Rick, why don't you just have this same exchange you've been having in the chat, in the voice recording here. Rick, what were some of the points you were making?
Well, this is interesting to us because your model, Jill and Dr. Leming, is very similar to what we do within our support groups, except ours is peer-driven and yours is medically driven. So technically, we do not provide medical advice, except on occasion we have peers who are also HCPs that allows us to do that, but we find our way around that. And there are people in this in the audience who have attended our groups, and you can listen to our support groups because we record a lot of them. It's all about finding the right quarterback. We try to guide people to quarterbacks that we know will sit and will listen. And invariably, we're pretty successful in doing that. Russ is saying, well, not all GU med-oncs are good. No, not all doctors are good. But if, for example, you're looking for treatment for prostate or GU, prostate is our mother load, but we have groups for pancreas, we have groups for thyroid, we have groups for non-cancers. And in every group, we make sure that the peer moderators are well educated. For some of these cancers, and particularly the GU cancers, I think it's impossible for a general practitioner to be up on general medical oncologist to be up on everything that's going on. They just cannot do it. There's too much. And as good as they are, and maybe they're well aware of the NCCN guidelines for, say, prostate, which I got to tell you, a lot of general medical oncologists are not on top of, and we are sending the patient the NCCN guidelines to deliver to their doctor. A general med-onc cannot stay on top of everything. But just on a broader basis, we're doing a lot of the same thing. We're helping people with their financial resources. We're talking about drug interactions. We have one of our moderators was a career pain psychiatrist at the VA. So he lived with with contrainterdictions and cross interactions. And so that's in his forefront. But I can't tell you the number of times somebody said, well, I'm on this drug and I'm taking that drug. And we say, well, those two don't really mix. Now, how, and we do this nationally. So, and of course, we don't worry, we don't have, we're not subject to HIPAA because we're all peer-to-peer. So I am so empathetic with what you do. I love it. I'm sure that we're going to have Florida people that will be able to shift over to you. But I think my biggest concern is in some of these high research areas, and rare cancers. I don't know how you can stay on top of it, short of making sure they're seeing the best doctors available to them. Sorry, I went on a little bit, but you're sort of touching a lot of chords, Dr.
No,
Leming. We'd
you're
love to talk to you afterwards.
no, you sound like you're part of the club here.
Yeah.
It's no, you're doing phenomenal, to be able to do that nationally and help that many people with what you're doing is just amazing. I think, but I think you're absolutely right. I think the volume, it's complex. The volume of information, as you well know, if you go to say the American Association of Cancer Research meetings, and they'll fill up a space of a football field with abstracts on boards twice a day for 5 days,
Right.
and trying to stay up on even one area. I think what you're pointing out is this will be one area where the machine learning world will be helpful, but you can't, you still need a quarterback to take care of people. And one of the biggest problems is the systems are not encouraging quarterbacks. The financial side of it is like your other person mentioned, is they're more interested in RVU stuff than they are the short-term 3-month spreadsheet rather than the long haul. And there's so many factors involved in any one group or person has a hard time reversing any of this. So we're all scurrying around trying to fill in the gaps to help people as best we can, but we're not able to get to the root causes, and that's the frustrating part. And in spite of that, the cost of healthcare just is ridiculous, and the cost of medications. Sort of a tongue-in-cheek approach. I did a calculation on some medicines using the gold standard per weight, and if you started the cost of medications per weight, you would be absolutely unbelievably shocked by the quantity of the cost per weight, and so we've got a lot of factors. But
also
like
to kind of
anything,
speak to
yeah.
like your big concern, and it's a concern across the board, because more and more and more of the academic facilities are getting to the point where the physicians are only seeing, one or maybe two specific tumor types. So then you're having a hard time finding a general medical oncologist. If you think about what a quarterback actually does, what makes a quarterback a good quarterback, it's not just the fact that he's calling the plays. It's the fact that he knows how to think, he knows how to think fast, and he knows how to pass the ball when he needs to, and how to find the person to pass it to. So if you look at it from a full analogy standpoint, it's not like we saw a patient a couple weeks ago that they were a misdiagnosis. In the process, we were able to figure out what the patient's actual diagnosis was. And their diagnosis ended up being something that there's literally like 6 cases that have been documented. There is no one that is going to be a national thought leader on that specific diagnosis. However, how do we get the patient to where they're going to get the best care possible? How do we connect their treating oncologist locally with someone who's going to be able to answer those questions? So it's about connecting the dots for the patients and making sure that they are getting the right care. And you really do have to call the shots. You know, there was a little discussion going on about GU patients and the NIH and National Cancer Institute. We don't send anybody to an academic facility or to a clinical trial. We don't make recommendations on facilities. We make recommendations on specific studies by specific investigators, and we connect the treating oncologist with those people so that the patient isn't blankly being sent to the Ohio State or the Cleveland Clinic or MD Anderson. Because what's going to happen is when they get sent there, they're going to hear only what MD Anderson has, or Sloan Kettering or Moffitt or any of the academic. You only hear what they have. If you don't have someone that is looking over everything for you and looking for what is the best trial for the patient, every academic facility is going to have a clinical trial that is great for that patient to go on.
Right.
Because they qualify.
I'd love to comment on that, because one of the biggest issues that we face is this academic conflict of interest, and it drives us nuts. You know, if you send a person, especially to an academic center, but even to some of the better non-academic centers, and they're running a trial, they'll push that person into the trial. Then we bring them back to us, and this trial isn't right, or this trial doesn't have an adequate control arm, or what have you. The docs don't tell you, and we've taken it up. We've taken it up with the docs. I mean, it's a huge, huge issue. And just as much as there's a financial conflict of interest with private practitioners, there's an academic conflict of interest with a lot of practitioners.
Well, and if the majority of the research is drug company sponsored, and and for young investigators, it's a requirement for them to put people on their studies, otherwise they don't get advanced in the system. And that's a large amount of the funding for the research. It's both in academic and non-academic centers is coming from the drug company. If they don't fill the quota on their trial, they don't get any more trials. So you have the thing that is, you have to know all these dynamics, like you're pointing out. You have to know all these dynamics and educate the patients on that. And also, I don't know, you're absolutely right on some of this. The concept that a doctor that you're seeing that is owned and controlled by a system in years past, you had the sense that they're independent, they have my interest only in mind, you would hope. Now you have physicians that are being specifically told from their system what they have to do, that you start wondering, is that in your best interest, or is it in the system's best interest? And so there's the whole nother level of interrogation of a system when you're sending them someplace. So when we send people, I ran the research department for 30 years at one of our big private hospitals. In the 30 years, I never put a patient on a clinical trial unless that was the best treatment. But that, I can tell you, that's not the way most places run.
Oh.
It's more like, is the patient eligible for that particular trial? Not, is that trial the best for the patient? But that's that kind of work you're doing. What I think a lot of places are trying to do is, we're trying to make sure the patient's getting the best care. And a lot of times a clinical trial might be the best care and the cheapest, but it takes some time and thinking and effort, and
it's hard because we try to empower patients and tell them, like, look, when you walk in with your physician, you should know almost as much about, if not more, about your diagnosis than your
Right.
physician.
Right.
You should be asking the questions. You should be pushing back. This is your life. You have a vested interest. So we try to empower them, but you also are also dealing with the fact that you have people who are currently functioning in the fear part of their brain, because if with new diagnosis, if they've got new metastatic disease, they're terrified. And so how do you empower patients to take the reins and to get in the
Right.
game when their brain isn't even functioning and at the capacity that it
Right.
needs to, because they're terrified.
Well, we can, I can definitely offline talk to you about that,
I
because
want to
we've
get to a
developed
couple
some
more
techniques
people.
that work.
I want to get to a couple more people. Chris and Helen have some comments in the chat. Chris, can you had a number of questions. Can you choose one or two that you want to focus on?
Sure. So just to clarify, you provide second opinions. So that means you're not treating the patients. Is that correct?
Correct.
And so one part would be, first of all, getting all the information together. So you have assistants and a team, or you get access to the portal so that you can collect all the information when a patient comes to you that kind of prepared for you, right? Because that could be quite a time effort to get this set up, to get started, right?
No. Yeah, we have a team of unbelievably gifted people that even in the middle of our consult, if I'm missing something that I need, Jill will text our team, and within 10 minutes, I will get the data from whatever system we need.
Okay.
It's just amazing.
Great.
We have a majority of the patient's records, and we do all of their records from the time of diagnosis all the way through what is current, and not just the medical oncology notes, but we want primary care notes, because it's not just about the cancer diagnosis, it's about the whole patient. So our team is well trained to know, like, if the patient has been seen by cardiology or pulmonology or nephrology, whatever ologists they have, they're pulling notes and records and labs so that we have the full picture when we see the patient.
And how often do you encounter situations where you feel the care is suboptimal, and that the patient? So are you then interacting also on behalf of the patient? Are you also connecting with the other ologists, oncologists, or hematologists, or whatever?
Yeah.
And so do you have one-on-one conversations? And how are they? Are they collegial, or could there be even situations where they feel kind of that somebody's looking over their shoulder, and that it kind of scratches on their ego? And how is that usually happening?
Well, it's first of all, I try to call the treating physician before the patient comes in. I also, if I get a call on a patient that's wanting to be seen by us, I will call the patient for a kind of an introduction prior to them actually coming in, because a lot of times I can alleviate a huge amount of anxiety that they're a 10-minute phone call can allow people to sleep better. It's like anything, our job is not to be critical. The bottom line is to make things better and to educate sometimes. It's like anything, there's ways of helping physicians do a better job, knowing that none of us are perfect, and that your job is and that we have the luxury of time. So you have to understand, most docs are sort of paranoid in general. They're under high stress. They're frustrated that they can't do the kind of job that they want to do because of the pressures they're under. And so if we see something that's definitely off, and it's rare that we see something that's deadly, but every once in a while we do. And if we do, then it's like the United Nations. Your job is to know that person a little bit, know how to approach them so that they, you know, they make sure they're doing the right thing, and that maybe the next time this comes up, they do it a little better. Every once in a while, you get somebody who's not receptive, but I'd say that's just extraordinarily rare. Most docs are appreciative because when we've done surveys, more than 80%, it's almost like 90% now, of all the patients go back to their primary doctors happier with their own doctor because we've been able to explain things that their doc doesn't have time to do.
Okay, so a lot is actually communication where the physician usually doesn't, the system doesn't, and allow the physician to have enough time to explain what is going on.
And if you would say the singular most significant problem in healthcare now is the failure to communicate.
Okay.
You know, across a lot of areas.
And that is something that we really make sure that we do well. The physicians get a full written consult, but they get called before and after the patient, and we typically will send an email with kind of some like the Cliff Notes version of what's coming in the full consult. But when I say, like, we do it the old-fashioned way. We pick up the phone and we have a conversation, because there's something to be said about having the connection and the back and forth and giving them the opportunity. And when we've found errors, there is definitely some finesse.
How difficult is it to get them on the phone? You have a team that coordinates that? Because I could imagine that
Leming calls all of the physicians from his cell phone. So if you're, and most of them have his contact saved, you know, a lot of the docs in the Cincinnati, Northern Kentucky, in our general area already. So if you see Phil Leming pop up on your phone, you don't send that to voicemail. So usually most of the docs either answer when he calls or they call back within the day. A majority.
So you have their cell phone numbers and you call them directly, and
yes.
It's okay.
And that's part of building the network to provide better care for the patients.
Understand. If you have patients who want to go beyond what's called standard of care, how do you handle that? So, for example, we have a functional oncology, precision oncology platform. So we can take patient tissue, we can actually test it on cytotoxicity or anti-proliferation of a range of drugs that could be within standard of care, or it could actually go beyond of that. If a patient is requesting that and the standard oncologist, often what's not within the guidelines is resisted, but there are treatments, and you are certainly also aware of it, that are outside of guidelines that are actually well documented to be effective, and sometimes patients want this. Do you help those patients, or how do you handle that?
So you're touching on an area that you know is a little touch. I think the way we approach it, or I approach it, is if I can't do better than guidelines, I need to not practice. Guidelines are what they describe. I separate out oncologists in those oncologists that do nothing but quote guidelines versus those that think beyond the guidelines. Because anything that's on a guideline is automatically somewhat out of date. And so, yes, you want to be aware of guidelines, but if you're working with at the level that you should, your level of thinking should be far beyond any guideline. Knowing that whatever you think is standard of care, there's researchers and people that are 5 to 10 years ahead of that. So once you understand that, you're forever tortured, because you can't just be happy with, say, a patient getting something on the guideline. They're important, but they're what they do. They're consensus things. They're guideline things. They aren't necessarily the best for that singular patient. And if you work on the philosophy like we do, which is if you can walk in the door, you're curable to proven otherwise in our eyes, and you don't want to be taken care of by a physician who doesn't have that mindset, because anybody that thinks that they know everything, then they're wrong, and that the research world and the science level is far beyond what's accessible on a guideline or a day-to-day practice. It doesn't mean you can always get access to all that, but your horizon should be in that level, not at a flat level guideline.
Okay.
So that's how you have to do this. So just because something's not on a guideline doesn't mean it's not a potentially, good thing. And a lot of the things that become guidelines were not well respected before they were proven to be helpful.
Right. So we had in one of our cancer patient lab meetings, Vikas Sukatme presenting, who was the dean of Emory at some point, and he has a Emory Morningside Center for Innovative and Affordable Medicine, and is actually with his wife is actually working on what they call financial orphans. So these are sometimes drugs off patent, FDA-approved drugs, basically repurposed drugs. It's one part, and we have a testing platform for that. But then there are also other phenomena where they observed that histamine levels plays a role on responsiveness on immunotherapies, but also there's good evidence for other interventions, especially in the early stage, such as nutrition as well as physical exercise and activity, so lifestyle interventions that are usually not discussed, or oncologists are completely staying out of this, even though there is good evidence for that. And they showed a meta-analysis that I was very impressed with that came out 2024 that showed that morning infusions correlated with markedly better outcomes in cancer patients, and they tried to implement that, and that was a meta-analysis on over 3,000 patients, 18 studies, and it's a quite consistent picture.
Well, it's
really difficult to implement that.
No, but what's comical about that is people are acting like they had a new discovery. If you go back probably 30 years, there was a whole push on chronobiology and chemotherapy administration, and there was I have the guy's book on my shelf that did a lot of incredible, phenomenal animal work in the chronobiology that was very strong, but it was hard to implement, so they didn't have it. The interesting part is the chronobiology of immunotherapy is the exact opposite of what the chronobiology of chemotherapy is. Chemotherapy is early morning. Chronobiology for immunotherapy was afternoon. And so there's, in a different life, I did about 15 years of nutrition metabolism in the cancer space. And we're extremely strong on pushing that. And I always tell people, ask what they can do. I always quote George Sheehan, who was the medical editor of Runner's World, and it says, "Do those things that make you a healthy animal." And it pretty much covers the ground, And we could talk a long time, but it basically comes back to what's necessary to keep you as an organism optimally functional and healthy while you're treating the cancer thing. And it's you should come here. We could have a lot of fun. Okay,
we'll do that. And we should have an offline meeting anyway. So I'm very interested in what you're doing. This is actually this is really, really important. And I think one of the challenges that patients have is educating themselves. And Jill, you said that the patients need to basically know as much about their disease as their oncologist. Unfortunately, I agree with you. The problem is So if you want superior care, you can't. If you want a superior outcome, you cannot just go with standard of care. You need to think about yourself, what you can do yourself, and you need to understand the disease. Now, not every patient is a medical professional, and not every patient has a college degree, and not every patient has the fields empowered to be able to do something about it. And I think that's a real challenge. I could imagine that there are some patients that are inherently, based on their background and profession and education, etc., are very well suited to take action and to be proactive and know what they're doing. But one of my concerns is it may not be achievable for a wide number of patients who do not have that mindset. It's probably also a question of mindset and education, and it's a really steep climb. We who live the healthcare have lived in the healthcare system. For us, a lot of things are natural, but for patients, they hear it for the very first time, 10, 20, 50 words that they've never heard before, and it's really, really hard, I think, for patients.
Yeah. We try to make it common sense, because if you really look at it, I mean, every cancer that you see, you can dissect into the same basic principles, and it's really very simple at its essence. And trying to, you can't. The complexity of the science is huge, but the basics are really pretty simple, and we try to emphasize that, And I think you're absolutely right. You have to be a chameleon, and part of the art of it is knowing how to insert yourself into that particular patient's world, and we always do it by, no matter how old or sick a person is, I never ask a person what work did they used to do. Every single person, no matter age or condition, I always ask them, what kind of work do you do? Because the impact allows you to open the conversation at a more personal level, and then you find out what that person's about, and only then can you effectively learn how you can educate or teach that person. It's a bit of an art form, but it really works.
As your moderator, I have to point out that we're past the hour. I don't want to impose on you or anyone else. Helen had a couple of questions. Jill and Phil, do you have another minute or two just to allow Helen to
Sure.
ask those?
Yep.
Okay, Helen, yeah, go ahead.
Oh, okay. Jill, did you want to address my question? Because it sounded like it's the one with the weight. I'll ask the second one after.
Hold on, let me
Oh,
go ahead and ask it again, because
oh, okay. I was just saying that in my 2-year journey.
Oh, your weight, the weight
Yeah.
question. I did answer that. So she was saying how, like, in the time that she's been getting treatment, how when she goes into the office, they don't weigh her. They just ask her how much she weighs, and they write down what she says. And my response to that was, I have literally watched Dr. Leming almost have a stroke in regards to patients that we were actively treating, that we look down at the weight, and the weight is the exact same weight for the last 3 visits. And we ask the patient, like, did you get on the scale today? And they say, no, they just asked me how much I weighed. I promise you, after that happened, that medical assistant never made that mistake twice. So this is one of those where if you find yourself in a situation where, I mean, because as Helen had brought up, a lot of the medications that are given are weight-based. They are calculated the day of treatment. If you are not getting on the scale, then it is not being accurately calculated. So if they just ask you how much you weigh, then your answer is, oh, you know what? I don't know. Maybe I should get on the scale. Play dumb. Get on the scale.
Yeah. Well, they don't have one. So this is like I mentioned I've had 2 big surgeries, 6 chemos, and 22 Avastin. It's always my word, what's your weight?
You've been to a medical oncologist's office and they do not have a scale?
I've not been. I have an oncology center at a big hospital here, and I've never been on a scale.
So
They
you
call
sounds
me.
like sounds like
Yeah.
you need another center.
Yeah, well, now it's over. I just finished it, but the point is that like Avastin, so I've lost 12 kilos in this process, and I'm always like shocked that they don't ask me. And Avastin, for example, it's as you said, it's by weight. It's like 15 milligrams per kilo. So if I've lost a couple of weights, and so anyway, that was my first question. It's because it's quite systematic, and I see people having very severe reactions, and I always wonder, and I always say, I don't know, did they over-medicate you? My second question was on an article, and this maybe is really not related to what we're talking about, but I was shocked to read recently that there's an article in the stat update by the medical journal that vital chemotherapy drugs used around the world have failed quality tests, putting cancer patients in more than 100 countries at risk of ineffective treatments, and so on and so forth. And so it was shocking to read how little the generic chemical chemo drugs and other drugs are being monitored for their components, and what's really weird is like this past 2 weeks, I've seen so many women in my ovarian cancer groups having having recurrence or just failed, and maybe it's just a time month or whatever, but it just makes me wonder, and I don't know where the generic drugs are going, mostly to poor countries, but definitely UK was mentioned as well. But I guess there's just no way to address this question for lay people or for the hospitals themselves because it's a regulatory thing, right?
Yeah, I don't have a lot of. I mean, the generic drugs are supposed to be passed through, testing that makes them equivalent, and so I don't know what the status of that is. I'd have to look into it more detail, but obviously you want to be able to trust that the drugs that you're getting, whether they're generic or brand name, are equivalent. And if they're not, then there's a problem.
Yeah,
So
it is supposed to be equivalent. The problem lies for the companies that are, or for the agencies that are supposed to be regulating it, like
yeah,
20% of it. Yeah.
I agree.
It's a shocking number of treatments, that people are getting either too much or too little. So yeah,
I think we should
one more thing.
wrap up, and
Yeah.
so I'd like to give Phil and Jill an opportunity to say any closing words that they would like to leave us with. Any thoughts, anything you didn't have a chance to say, whatever.
Well, I'd say what our general role is, we're kind of like oncology grandparents. We get to play with the kids and send them home. You stick to the basics. Like whether it's getting the weights you're talking about, or somebody doing a simple examination, or it's taking a stethoscope out to listen to your lungs. The basics do not change. You have to be aware of the technology and the new science, but you cannot give up on basics of medicine. It's been stable for centuries. And I'd say that's the biggest message is, that's the part that's important. And communication, it's like just life in general. The things that get most people in countries in trouble is not communicating well. So, it seems like there's a whole lot of people doing good work. And Brad, I can't give you enough accolades for pulling all the people together that you do, and all the work that you've done to help so many thousands of people. I know I've said it, but we're so grateful for all the help that you gave us to get started, and the continued help that you're doing with this program, obviously. So you need to get a gold medal for sure.
You're welcome, and thank you for the kind words. Jill, did you have anything you wanted to say?
I would definitely say, just especially with the group that we have here, I think I'm probably preaching to the choir, but patients are going to have better outcomes if they get engaged in their care and they are not a passive participant. they've got to challenge, they've got to ask questions, and we've got to figure out the way, like Chris, what you were saying, all of those things are absolutely true. But the reality is the uneducated patient who doesn't know what questions to ask, those aren't the patients that are seeking support. Those aren't the patients that are engaging with additional services. Those are the patients that are being spoon-fed whatever answer the doc is giving them, and they're not questioning that at all. So we have to figure out how to engage the patients and how to empower them to be part of their own journey, and not just take everything at face value.
Yeah, if anybody remembers Bernie Siegel in his books many years ago, where he described the patients that were somewhat of a pain to the healthcare world because they push back and ask lots of questions and harass things, they also were the group that did the best and lived the longest. But that's, it's recycling the same knowledge that was, brought up in the past, like a lot of things.
And we used to do that all the time. When we had patients that would come in for new consults, I would say, please be a pain in my ass. Call, ask the questions. Don't just sit at home and worry about something or have a side effect that you think you just should be having because you have cancer and you're getting treatment. Call, ask the question. Bug me. That's what I'm here for.